Hi, everyone. Thank you for joining us, and thanks to everyone who's joining us online. I'm Barney McManigal of the Graham Project, and I'm welcoming you on behalf of our hosts, Professor Ben Cooper and Professor Christian Dolacek. We have a great program lined up this week, and we are so grateful to our speaker, Dr. Geetanjali Kapoor, for coming to Oxford and giving this series of talks on AMR surveillance best practices. Dr. Kapoor is the acting head and a researcher at the One Health Trust based in Delhi, and she comes to us as a visiting fellow and recipient of the Hamid Foundation UK-India AMR Visiting Fellowship Scheme, which has made these talks possible. This is her first session, an introductory talk on AMR surveillance challenges, which will provide an overview of what she will be talking about during her 5 days in Oxford. Trained as a physician, she is a clinical microbiologist with research interests in AMR surveillance, infectious disease and outbreak management, health systems strengthening, and health policy formation. Given the seriousness of AMR and our antibiotics crisis, I can't overstate the importance of what she has come here to share with us this week and the value it holds for researchers, clinicians, and professionals across global health. So thank you again, Dr. Kapoor. Just a few housekeeping items. For those of us joining in the room, the fire exits are out that door, and to the right, you will find a staircase that will take you to the rear exit of the building. And for those joining online, this lecture series is being recorded and will be shared on the Global Health Network platform. To automatically translate the speech to subtitles in your chosen language, navigate to the closed captions function and select your language. Due to the number of participants, your video and microphone have been disabled. Please use the chat function to introduce yourself or to report any technical issues, but please do use the Q&A function to post your questions and comments. You may do so anonymously. We expect that there will be time for questions at the end of each session, so please do send your questions in the Q&A. And without further ado, I turn over the floor to Dr. Kapoor.
Thank you. Right. Thank you so much for the invitation by the Oxford team, Dr. Christian Dolacek, Professor Ben Cooper, Barney, your entire team. It was great coordination you all did and made that possible for me to be here today. I'll be quickly just first, so Barney has given my introduction. I'd like to just go over the agenda. So this is going to be a 5 days conversation. And why is this topic important? AMR surveillance, we all know. I mean, we had the UNGA just about 2 weeks back, and we had all the global stakeholders there. We know antimicrobial resistance is a pressing problem, just not because it's been stated by international organizations, but also in our day-to-day, our own life. We do see that this issue is indeed important, from newborns to elderly to those who are just not critically ill, but even in good health. If you fall sick, many a times we need to keep changing our antimicrobials. So hence, AMR is indeed important. We need to mitigate it. And that is the reason I'm here to just discuss, and it's not going to be a technical discussion that I'll be doing. It's basically to give an overview of how do you, in the end of this 5 days, I would like all of us should understand how do you build a surveillance program or a surveillance system. That is my intention. That's the objective of these meetings. So, well, I'll skip this. This was the audience that had registered. And to begin with, my sincere thanks to the Hamid Foundation UK-India AMR Fellowship. So they have supported the Academy of Medical Sciences, and the the program is around building collaborations between the AMR researchers in India and in the UK. So this started about 4 years back. And this is the 4th round of fellowship for which I was also given the award. And as a part of this, all the awardees, they were supposed to tie up with an institution either in India or UK, depending on where are they based. So I'm based in India. So I tied up with University of Oxford, and the topic had to be anything around AMR. So I chose AMR surveillance. And Professor Cooper, Dr. Donald Barney, Sabala, Sophie, and my team here from the Gram Health Network. Thank you so much. The agenda. So as I mentioned, this is a 5-day series of lectures for about 2 to 3 hours each day. Today, of course, is the first day. I'll begin with the first session, which is going to be an overview, just an overview to talk about what AMR is. It's just the traditional way of introducing any topic. So many of you already know more than I would be actually telling, but it's just to kind of be on the same page. And then I'll have a second session also today, which would be after an hour. And that would be a little more technical around, what are the methods for AMR detection and a few definitions and what's the global arena doing. That's it. That's just for today. Then for the next 4 days, it's going to be around how do you actually make a surveillance program. So there are lots of those programs already existing as a part of either national programs or as a part of various funding programs. And I'm sure most of my audience, which is either online or in the room, you all have been part of this. I also have the opportunity of supporting surveillance programs in my past work, both in the current organization and prior to that. So I thought it was a good opportunity to just share my experiences with all of you, also hear your experiences during our discussion session. And the next 3 days, that would be basically around, I've divided the next 3 days into specific programs. So tomorrow we are going to be discussing about how do you initiate that surveillance program, or how do you engage with different people, how do you do a lab network mapping. So all that's mentioned there for October 10th. The next day would be a little more critical because we talk about how the data is collected, checked, rechecked, analyzed. That's actually the most, I would say, humongous task for any surveillance officer. And then how do you disseminate those findings? On Monday, we talk about the formats generally. So when I say anything, it's not etched in stone. All of you are free to, of course, tweak your program as per the context you're working in. And I would like to also, emphasize that everybody brings a different skill on the table. So when we talk of a surveillance program, it's not possible for one person to do. I have personally seen that. I mean, it's great to have a great team. Everybody's together here, and in the end, I think that's what makes the difference. You have the right people on the team to execute the project. So that is the beauty of just not surveillance program, but any global health program. That's important. And and so we will be concluding on Tuesday. So this is the first session, a very general talk we'll be doing about an overview on AMR. So AMR stakeholders, we all know, all of us were most likely watching the events happening over the last 6 months across the world when everybody was trying to already advocated around the importance of AMR mitigation. We had lots of stakeholders there, and most of them were there at New York 2 weeks back. So who all are there? Who all are these stakeholders? This list is not comprehensive, but I tried my best to include all the players that are definitely, there in the limelight all the time. UK Department of Health and Social Care, of course, they are there. They have supported various schemes, including the Fleming Fund, the Public Health of England, the GRAM, and other academic institutes. US also has taken a lead here. The BARDA, the CDC, NIH, the European agencies, and the FDAs, all these organizations. So every player mentioned over here has a different role. Some could be through a government support, some could be more like funders, some could be technical partners, advocacy. For example, we have REACT, and REACT is more of an advocacy partner, and carries more into vaccinations. Every player here is touching upon the mitigation of AMR in some way or the other. Of course, not to forget the big role that pharmaceutical companies are playing, research and diagnostic firms, citizens. I think citizens are so important, and they, of course, have been, it's been highlighted in the Global Action Plan on AMR, the role of bringing in awareness amongst the common man, the youth, the children, and just everybody through various advocacy groups. So these are the stakeholders here. And before we talk about antimicrobial resistance, I'll step back and remove the word resistance. I'll just talk of antimicrobials. And when we do talk of even antimicrobials, we basically first start talking about penicillin discovery. Of course, that was a big groundbreaking discovery, but we also had various other antimicrobials which were there. We had quinine. Quinine is a natural product, so it was not a discovery, it was an extraction. And this happened somewhere in the 1600s, maybe even earlier. It so happened that there were some people, like they were not well, they had high fever, and they were taking a bath in a pond in one of the countries where malaria is rampant, and they suddenly healed, And why they healed is because the trees over there, they basically had the quinine in them that got percolated in that water. So that's how it was a serendipity by which quinine got extracted and then finally isolated in 1820, even way before penicillin was, by doctors at the School of Pharmacy in Paris. And of course, penicillin discovery, we all know about that, 1928 by Sir Alexander Fleming, very much in London at the St. Mary's Hospital, and the Nobel Prize was awarded to him in 1945. These are very important milestones, hence I would like to talk about it. The first fungus which got discovered was nystatin. That was by women scientists, Dr. Elizabeth Hazen, a microbiologist, and Dr. Rachel Fuller, who was a biochemist. So this was at New York. So this is so interesting. We are also talking about other antimicrobials. So, and the fourth one on my slide is idoxuridine, which is an antiviral. And discovered by Dr. William Prasov at the Yale University, also used for treating HIV. So these are for both the parasites, the fungus, the bacteria, and the viruses. Now, after this, many more antimicrobials came up, discovered, used, misused, and then, of course, what happened? And that's what we're going to talk about, its resistance. So let me talk about the antibiotics. So on this slide, thank you to the antibiotic threats resistance report of the US 2013, from where I have drawn out some important points and drafted this slide. So, as I mentioned, penicillin was introduced in the 1940s. And you can see on the top, I'm talking about the various antibiotics during different, we made the intervals into 10 years just to show when they were introduced in these different decades. And then at the bottom, you can see how resistance actually followed the introduction of these antibiotics. It was penicillin resistance, which came up in staph. We know penicillin does not anymore work on staph. It's resistant. No guidelines even recommend that it should be administered. And then in the 60s, it came up for Shigella. It was noted to be tetracycline resistant. MRSA came up, and we all know staph is methicillin resistant. We don't give those drugs anymore. And like that, it goes on. And now it's so pressing that we have extra drug resistance in just not TB, but even in other non-tubercular bacteria. We have VRSA, pan-drug resistance has come up, and actually very less of new drugs are also being developed, unfortunately. The reason being, again, very much known to most of you, is that it doesn't offer much return on investment. So the bacterial pipeline is also quite dry. So a big cause of worry. Now, as I mentioned, this entire session is around very generic. I'm going to be just going generically around AMR, how the resistance comes up, what are the accelerators. Now, AMR is a natural phenomenon. It just happens. It's been happening since ages, even before we kind of started noting it in our patients. It's been there. It's just the way a bacteria survives. It's their survival instinct. But despite that, it's also this natural phenomena is getting accelerated. How is that happening? It's just like you give more of a trigger to something, and it starts creating a shield around it. So every time I kind of myself start thinking about these reasons, it's all there in the literature. I thought it was good to just club it into two broad categories. When do the microbes numbers are increasing, and when are the antimicrobials number increasing? It's basically that kind of conflict. When you have more of microbes, those situations, and more of antimicrobials, that the war between these two actually is leading to a resistance buildup. So let's, maybe I can also love to hear from the audience. I already have it on the slide, but situations where the microbes are more. So we know in the hospital it does happen when the infection control is weak, it's poor, it's not being implemented. You will have more of the bugs spreading all over in the environment and on the patients. In the community, likewise, it could be when you have a poor sanitation, the clean water is not there, hygiene is not being maintained. Again, it is going to lead it to having more of bugs all over. The vaccine coverage is less. Again, another very important reason. You do tend to start getting infected, indicating that there is, again, extra microbes in the environment. So these are the three top reasons when our microbes are on the rise. What about more of antimicrobials? Now, when I say more antimicrobial, it basically means overuse, misuse, and that could be happening in the hospitals where the stewardship is weak, you're not having. So of course, stewardship is being followed in good institutions, tertiary hospitals, developed countries. Even in the low middle income countries, we do have institutions which are practicing good stewardship practices, but that's very few, and in most of the setup is not being. So again, that gives a chance of throwing in more antimicrobials, which of course then hit the bacteria, and it leads to more resistance buildup. Regulations, again, if you don't have regulations, it is going to lead to overuse on the counter prescription of drugs. So that is actually a very important cause of concern in most of the countries, even in India. There is an overuse of antimicrobials because it's now being even prescribed by the chemists, which are maybe just all over the place. They are prescribing without any doctor's prescription. And sometimes people just on their own, they're not well, they just follow up with their old prescriptions or their neighbors or their friends, and they got sick and they were prescribed, say, Norflox, ciprofloxacin, and then everybody who gets that similar syndrome or clinical features, they all start popping in the same drugs. So again, that's happening because there are no regulations. Then disposal practices. You're disposing the unused antimicrobial in the garbage, or maybe the pharmaceutical firms are just disposing it in the external environment. There are no regulations, no guidelines how it should be. So these are very important areas where we need eyes, we need mitigation, we need policies on, and it is happening, but there's a long way to go. Another area where we do have more of antimicrobial interactions is now being recognized. It's in the environment, especially water, which is a confluence from different sectors. So from the domestic source, from the hospitals, from the farms, animal farms, agricultural farms, pharmaceuticals. So it's kind of like a cradle where everything is just getting pumped in, the microbes, the antimicrobial, that it becomes a very interesting and a conducive place for the microbes to start building the shield around them and even interchanging their genetic material with other microbes in that pond or in that pool of both backgrounds. So these are various factors. Of course, I have not maybe covered all, but these are really something which we always talk about, and accelerating the phenomena, the natural phenomena of AMR. These are basically the man-made reasons why we are accelerating the natural phenomena. So when we talk about AMR, I think it's so important also to know just not the language or the description, but also quantify it. Have we really quantified it? Do we know what's the burden? Is it easy to quantify it? And there is no clear answer for this. We can differ in our thoughts, but honestly, it's for sure not an easy task to quantify something like AMR. It's not an isolated problem that's occurring in a defined community. It's across just everywhere. It's now a One Health problem. It's in all the sectors, and hence not very easy to quantify. And that actually is the reason why the importance of surveillance comes into being. How do you make this task easier? You make it more defined. You have some kind of a structure in place that is so much needed. Now, when I say it's not easy, it doesn't mean it has not been done. We do have lots of research going on globally. Research groups are trying to demonstrate what's the burden of AMR across both the humanistic domain and the financial domain also. So again, I have only on this slide, as you would see, I'm just showing the 3-4 very, very commonly talked about sources. We had the report from Lord Jim O'Neill, which was in 2014, and it was global in scope. They were done on modeling methodologies. And what came out from there was that about 700,000 or 0.7 million deaths were basically attributed to drug-resistant infections. Now, this included HIV, it included TB, malaria, and of course, even the bacterial infections. And with the prediction that if no action is taken, the deaths will rise to 10 million per year by 2050. These are something which I'm not speaking for the first time. We all know about it, but I thought it was important to at least talk about it in today's talk. That this is really important to note. Now, 5 years thereafter, 7 years thereafter, in 2022, Lancet also, and that was by the Graham Group, they published in the Lancet report, and that was based on 2019 information. Again, it was a global picture which was provided, and that mentioned just almost the double of earlier numbers. So touching about 1.27 million deaths were attributed to AMR. And then the associated deaths were 4.9 million, and of which about 20% were in the pediatric age group. So again, very concerning, and I do know that Graham has also released another recent version, maybe a few days back. I don't have that on my slide, but of course, everything is spiraling higher than all these numbers today. Even CDC, it pulled out a report, the Antimicrobial Resistance Threat Report in 2019. The scope was, of course, just in the US. And they mentioned that the drug-resistant infections is about 2.8 million cases, and the deaths attributed to AMR is about 35,000 in the year 2019. So that's about just, again, giving a snapshot. As I mentioned, my talk is more around an overview and trying to talk about the numbers. But this is not enough. This does not give us a full picture. This is basically modeling studies. It's not always coming from the real laboratories or the patients. It's also a lot of prediction which has been put into it. But why? Because we don't have a surveillance system. And hence, again, comes the importance of having the real data from the real patient in a real setting, and we need to have very strong surveillance systems in the globe across all the regions. Now, the lower table is talking about the AMR impact by 2015, and this is again by the World Bank Group, and in 2017, a publication was out. They have also given very scary numbers. And if I read that, the decline in global livestock output by 11% is going to happen because of AMR in 2050. The decline in global exports is going to be, again, between 1.1 to 3.8%. Now, the range is because they talk about AMR in low settings and high settings. So that's kind of a gradient they have given. Then the decline in GDP also 1.8 to 3.8% is going to happen by 2050 due to AMR. Expenses in the healthcare will spiral up. It would be almost 1 trillion plus in high impact scenario. And the rise in global poverty also is going to be almost 24 million people more pushed into this extreme poverty zone if no action is taken against AMR. Also, they did mention that the decline in GDP to almost 3.8%, it is akin to the economic losses we had in the year 2008. So it's almost akin to that, and again, very concerning. And as per Lord Jim O'Neill's report, he also did mention that the decline in global economy would almost lead to a loss by 100 trillion if the MR is not tackled. And by 2050, that's going to happen. So again, this is just a snippet of all that we know. Much more information would come out over the next many years because of various studies that are still going on by various research groups and of course future surveillance programs. Now, again, as we know the researchers who have done this great work and brought all these numbers up on the table. There is a lot of challenge in quantifying AMR. It's never been easy. It's not something like you just kind of say, okay, how many surgical site infections you have, or how many cases of, say, what's the compliance of hand hygiene protocols. It's not as easy. We are talking about not one bug or one drug. We are talking about so many different combinations of bugs and drugs, and quantifying that is not easy. So there are challenges. So if we try to dive into what are the challenges in AMR quantification, I think for me, I would say, and I'll be happy to hear your thoughts, but I think we can divide this if we use the WHO health systems building block as kind of a guidance. They actually fall into all these 6 different categories. So why are we not able to quantify AMR? Service delivery. It's really weak. We may not be having the institutions really ready to detect AMR. The labs are maybe not strong, or they're not even available. We do know from our experiences that many areas don't even have a healthcare facility or a diagnostic center. So the service is not even being delivered. So definitely, if you don't even have a service, where would you even test for the resistance? And it's then, of course, even more difficult to quantify it. So that is one of the challenges. Coming to the workforce, again, same story. Even if you, first thing is that you may not even have enough trained doctors, laboratory personnel, field workers to basically work on the issue of AMR detection and that surveillance. Or even if you do have, they may not be trained well enough. So it's a mix of both the numbers and how well they have been trained, both quantity and quality. Information, paper-based records, they are still there, not just in the developing countries, but also in the developed countries. We do know systems are paper-based, they are manually recorded. It's not easy, like if you need to cover up an entire region or a hospital, look into all those paper-based records, converted to useful information, knowledge, build up some evidence. It's really a humongous task, and researchers who do that, they do know it's not easy. Many a times, and we'll dive into all this eventually when I have my next session. We'll go into more detail on what are the various challenges. But we also know that many a time it's also so difficult to track records of the same patient, maybe after some more time, after 6 months, if he comes again, if he is being given a new hospital identification number each time, that again leads to a lot of issues during the research period. So when the researcher is on the field and he wants to see whether patient XYZ, what was his antibiotic which was given, say, after 6 months or after 1 year or 2 years, it can only be easily done if the same patient ID is maintained every time the patient comes to the lab. If the number keeps changing, again, it's going to be, we'll be counting the same resistance information multiple times. So it could lead to overcounting, a lot of bias. Also, I mean, I'm not saying this happens everywhere, but these things are issues which need to be tackled. Also, if we need to understand the patient's clinical history, the field worker, he can only do that if the laboratory records, so say the researcher goes to the lab first, he pulls out the lab records, and he has everything on paper. Somehow he manages to transcribe it, he puts it into his data collection device which he has, he does all that. And now you have also told your field worker, now you go to the hospital and also try to see what is the patient's clinical history like. Go and check from the ward or the outpatient department. And then the field worker, poor guy, he has the lab records, but then he doesn't know how to track this patient in the hospital for the simple reason that either the hospital IDs are different from the lab IDs, or when he does go to the hospital, it may be again the same story, everything is on paper. So we need to really have very strong information systems for having continuity in monitoring patients' medical history. Then coming to medical products, vaccines, technology, again, a lab can only test to the extent that it has been supplied with the essential diagnostics, the essential drugs, other testing material. So all these things, if they're not in the lab, of course, the lab is just not able to do any AMR testing. If you do not test, you can't quantify. You do not come up with the real burden which is there. Financing, a very important element as per health systems. Now, this is just not actually AMR. You can also apply this to any other global problem. All these 6 pillars actually fit in most of our health systems issues. So financing your lab or your hospital is not being financed enough. You're not able to either upskill your researchers, or you're not able to obtain the essential diagnostics for equipment, consumables, or even maybe apply for some external quality assurance programs because you're not being financed now. So it's not that the lab people don't want to do it, but yeah, if they don't have that additional, support coming from the in charge of the lab, or the region, or whatever is that area, it's going to be a big issue. And of course, leadership and governance is so important, because I think all these things finally do fall under how well can the head of the lab or the head of the institution really push for developing these various different streams in improving the systems. So because of these challenges, and these are real world challenges, and I'm sure you'll all agree with this, because of these issues, indeed, estimating the true burden of AMR has always been an issue. We do not have reliable estimates. We do have estimates definitely coming from all other kinds of studies. It's there from your predictive modeling, your ID modeling, all those, machine learning algorithms, which are now also being used. So those things, of course, do help in providing some kind of a figure, but we don't have the real data coming as we would have expected. So this is actually about the first session. The first session was all about this: what's AMR, what are the challenges, have we been able to come to some kind of a quantification? If not, why not? And then my next session has to begin after some time. But I'll take a pause here. I'll be very happy to answer questions and even hear your ideas and try to make this more interactive.
We do have at least 2 questions from the audience online. The first question is, which antimicrobials see resistance develop based on environmental waste? That's the first question. And the second question is there any sort of common electronic platform for collecting AMR data globally?
Okay. The first one, well, there is no one drug which you would say would get resistant. As I said, everything finally does spill into the environment. So any bug drug, it just depends on how much stimulus is being given to that particular combination. It would be very unfair, and that's quite kind of a very tricky thing to answer also, that which drug is more prone to getting ineffective in the long run. I would say it just depends upon various factors. There is no one factor. Even if it's in the environment, what other predisposing factors exist? For example, it would depend upon level of pollution out there in the water. It could, so in every setting, this is going to be different. What about the temperature, the humidity, the rainfall, various other geographic and climatic factors? So I think it's going to be, in the long run, a mix of all these various components that would determine in which group, bug drug group, would there be a higher potential of developing resistance. Again, mix of different factors will decide that. And the second question, I believe, was on surveillance platforms. And in fact, I will be talking about that in my next session. But we do have the very well-known global platform, which is GLASS by the WHO. And that's in fact also helping the countries to strengthen their surveillance systems, because it provides something like a ready-made methodology on how should data be collected, cleaned up, and plugged in the GLASS modules and GLASS platforms, and then sent over for analysis. So it's also kind of helping countries build up their own system and identify which are the centers, which are the labs, which actually can be called as labs participating in the GLASS network. So one is GLASS, then in Central Asia, you have the CSER, you have the Relavra, and we also have various industry platforms. So Pfizer, Merck, they all do have a lot of AMR data, which they have been collecting across a large number of years. So also providing a lot of support in strengthening surveillance systems. And all this data also goes to Vivli, another platform which is collating data from all these various industries and pharmaceutical firms, available for further analysis by various researchers. So I hope that helps in answering the 2 questions.
Yes. Any questions in here? Got some more online. An additional question. Somebody writes, in our hospital, we are not following stewardship guidelines. Is there any protocol or guidance that you can provide or tell us about that will guide us?
Sure. So again, the WHO has given a very beautiful guidance document on the toolkit, the stewardship toolkit, which can be used. It's very easy to follow. And they also provide trainings to those interested. You can check when is the next training. And it would give your team, your researchers, a good, understanding about everything about stewardship, how it should be built. The document was made in partnership with BD, and also Dr. Dilip Natwani was one of the very important figures who had helped in creating this WHA toolkit for stewardship. So I would encourage you to look into that for sure. That's one of the base documents that we normally go to, is to go to document for all of us.
Thank you very much for the lecture. You mentioned difficulties with quantifying AMR. Do you have any comments or insights into the methodology of attributable versus associated, and conceptually what the implications of that conceptual definitions are?
Yeah. So when you say attributable, it's more like, it's like you're saying, yes, it's certainly the patient died because he had resistant infection. That's where you use the word attributable. But when you say it was associated, the AMR death, the death in the patient was associated because of AMR, it was that he did not typically die because of a resistant infection. He died because of some other cause, but yes, he was also he was carrying a resistant infection at the time of his death. So these are two very different terminologies. It basically depends upon how well could you capture the patient's clinical history, the patient's records, was it well explained. That gives you the full picture. So as an example, I'm just throwing it out of my cuff. A child, a newborn baby who's actually, let's say, 28 days old, ends up having a community infection, really falls sick, given all kinds of antimicrobials, and just succumbed. And he had no other issue, no congenital defect, nothing. That case would fall more towards it. You can say that the drug resistance was the reason for his death. But let's talk of a 90 years old gentleman who's having multiple diseases, diabetes, maybe rheumatic heart disease, or like kidney issues, whatever. And he does also carry some kind of a resistant infection, but his death finally happens because of a multitude of other organ system failure, and not typically because of the drug resistance. So there we'll say AMR. So his health deteriorated for sure. Everything played in deterioration of his health, but the actual cause of his death was not a drug-resistant infection, but drug-resistant, he was harboring at that. So there we'll say it was associated. So those are the two different things. And of course, all this is given very clearly in the Lancet reports, which has been published by the grant group. Maybe I encourage you to read that for getting your understanding and learning even more.
Some more questions online. Somebody asks, is antimicrobial residue testing a relevant parameter for AMR surveillance? And another question is, are there antimicrobial resistance surveillance guidelines for hospitals? And then the third question is, somebody from Gambia, we have just completed an AMR stewardship project in our hospital in Gambia. We formed a committee, but it seems that sustaining this team might be a challenge. How do we avert this?
Okay, great. So we begin with the first one on the residues, the AMR residues in the environment. Is that right? That's the question?
Yeah.
Is it important to?
Is it a relevant parameter for AMR surveillance?
Yes, it is very relevant. We need to know what are the only thing is that there are no, maybe no designated figures. It's still being published, what are the acceptable limits for these residues in the environment. So the last I know of is that the research group, which is basically working on the environmental surveillance of AMR, they are still trying to bring in the acceptable limits. So it's a field still evolving, but of course it is very important. I would never say that it is not important for AMR surveillance, especially in the case of environmental surveillance, it is. The next question, Marnie.
Yes, because are there antimicrobial resistance surveillance guidelines for hospitals?
There are no guidelines, but the hospitals themselves can create their own guidelines. There is no set global guideline. I mean, that's why we are here for these kinds of capacity building meetings and discussions. I would say that it's not a new area. Surveillance has been going on for a long time. Research groups are doing it. Many hospitals may be having these guidelines, many may not be having these guidelines. So it basically depends upon, creating, and there is no one size fits all methodology which can be applied to all the settings. This also will vary depending on the scope of your project or your study. Are you doing it one time, or are you going to be doing it regularly, year by year basis, forever? It again depends upon your facility. Is your facility part of a bigger surveillance group? Is it a standalone facility? Is it a private hospital and just creating your own, surveillance program? So there is no one Bible which I would say exists, but there's a lot of excellent information. And if you go through that, you can for sure create your own guidance or guideline for your hospital. Yeah, and the next one is about, I think, somebody from Gambia had asked.
Yes, they've completed an AMR stewardship project. Their hospital in Gambia, they've formed a committee, but it seems that sustaining the team might be a challenge. How do we avert this?
Yes, I would actually first encourage you to read, if not, the WHO toolkit, because that actually talks about exactly the issue that you are alluding to. And here we do need a lot of support from your administration of your hospital. They need to really closely watch this, because containing AMR is not a role of the infectious disease department or the role of, say, the lab. It's the role of just everybody in that hospital, and I think they're all being guided best by the administrators. So they need to actually bring in this kind of a culture that stewardship is so important, and your teams need to be trained well. You need to figure out why is there attrition, why is it difficult, is it resource consuming, or any other. So you need to first identify the reason why it's not sustainable, and then maybe discuss internally with your own team and see how best it can be stepped up or at least continued. Yeah.
Some more questions from online, from the audience. I'll go ahead. Okay, so somebody's asking, maybe you've already addressed this, but are there AMR surveillance guidelines globally? How can it be accessed?
So do check out the guidelines from the GLASS platform. Read that, and that gives you a very good picture about what surveillance is all about. Do a research on various kinds of research articles, publications which are there. Do read about the Fleming Fund reports too, which is the countries have it all on their websites. So go on ASLM and look into that too. That also talks about the studies which have happened recently. And apart from that, WHO, I think in the early 2000s also had pulled out a document which was on AMR surveillance, a very primordial document, but for sure it does lay a skeleton, a framework, a sketch for further improvement, and also just gives you a very good picture on how you can make a surveillance study and surveillance program. And of course, we'll also talk about in the next 3-4 days on what are the various steps, even if you don't have anything, how can you do it? As I mentioned, it's a team, you need a team. And if everybody in your team knows what he has to do, and you have support from your, some kind of an administrator or a funder, of course, you yourself can do that. It's not rocket science.
I'll just keep going. Somebody asks, in resource constraints situations where lab analysis and services aren't available, how can AMR surveys and surveillance be done?
That is actually what we want to advocate through these workshops, is that if you don't have that, we need to in fact advocate to your government or to your institutional head that we need that kind of facility, we need that kind of financing governance to build facilities for testing, or alternatively, maybe you can tie up with other institutions which are already doing that. So they mentor you, and then you kind of start from a scratch to understand the various building blocks under their shadow and create your own systems. But we can't say if you don't have it and you don't do it, because I mean, that's what the whole idea is, and the real world challenges are there. We need to fight it and we need to create systems. If you want to achieve larger goals that have been laid by the UNGA to decrease deaths by X% in the next 6 years, 10% AMR deaths should be reduced by 2030. If we want to do that, of course, we need to also see and do a landscape assessment.
Somebody asks, how do we quantify AMR burden when you have AMU and antimicrobial consumption and AMR surveillance data in place?
So how do we quantify it?
Burden,
Yeah.
AMR burden.
Right. So again, when we talk about burden is a very, it's a very generic word. And for your study, what exactly is the objective of your study? Is it just to look into telling the resistance rates for a bug drug, or is it beyond that? Are you looking into the diamonds? Are you looking into qualities, deaths? What are you looking at? You need to first identify the scope of your study. And the more information you have, the more kinds of permutations and combinations you can do. For example, if you have information on usage and consumption, you can in fact quantify AMR even better. You can talk about the drivers of resistance. You can talk about how is the usage affecting or driving the resistance. So you can do those kinds of calculations, and that again would further help your governments or your local administration or team to decide on so that's the evidence you're giving back. Okay, this much usage was there, this is a resistance that came up, now what next? And then they're going to be saying, all right, so you need to cut down using these antimicrobials, and your stewardship practices perhaps are not good, or the regulations are weak. So those things finally would have a repercussion, a positive repercussion on containment measures by the authorities.
Yeah. We have a few more. Shall we take just one more question and then finish? Yeah. Okay. So somebody is asking, what are we doing about AMR in animals and their residues in animal food products, particularly in developing countries? This is somebody from Nigeria.
Right, so we are having now, and I'm sure you know about the quadripartite also, which has been working. It's AMR is not a human health problem, it is a one health problem. WHO, of course, is a human health arm, but the OIE and the World Organization for animal health, and the UNEP, the FAO, they all are working together, and we need to have more collaborations between them. And we need to also look into not working in silo. For example, we may be talking more, of course, the focus will always be on surveillance and human health, but we need to replicate that kind of a methodology in animal health, in agriculture, in environment. Then you have the tracks, which is there, which is tracking the surveillance and how much is the countries compliant to various prior guidelines, how are they performing. So all these things need to be very carefully looked into, dealt with, and intersectoral collaborations are needed for AMR mitigation. This is a tough area. I mean, surveillance is unless we do surveillance strengthening, we'll not be able to move ahead. We may make millions of goals and everything, but till our ground is not having, the rock is not strong. Other things would only be as much as we can predict.
Thank you very much. Should we
So,
thank you, Professor?
yeah.